drug-eluting stents or bare metal stents? Can pathological data actually shed light on the matter? Welcome to the Clinicians Roundtable. I'm your host, Dr. Larry Kaskel. My guest today is Dr. Renu Virmani, President and Medical Director of the CV Path Institute in Gaithersburg, Maryland, and a clinical professor of pathology at Georgetown University, the University of Maryland, George Washington University, and Vanderbilt University. Dr. Virmani is internationally recognized and has received numerous awards and honors for her work in cardiovascular pathology. Dr. Virmani, thanks for coming on the show.
Thank you.
Well, you have looked at every stent on the market, it seems, and you've seen the stents do their job in animals and humans. So what is your current opinion in 2008 of the usage of stents for, let's say, someone with stable angina?
I think in stable angina, there is certainly use for drug-eluting stents. They do reduce restenosis. That's what their main function was. That's why they were created. And they certainly reduce restenosis. But the question really is, in a large vessel, which is 3 millimeters or greater, do we need a drug-eluting stent? You know, they also cost a lot more. So I would say that in a large vessel, there is no need to put a drug-eluting stent, and that we could use a bare metal stent. But in small vessels, certainly, I think bare metal stents do not work very well, and in fact, you do require drug-eluting stent. But there are drawbacks of drug-eluting stents, as I think you know and all of you know, and that's you have to keep the patient on antiplatelet therapy for at least 1 year. So if it's an elderly patient, 70 years or greater, should you be putting drug-eluting stent because he may need to go to surgery? And nobody wants to do surgery. The surgeons don't want to do surgery if the patient is on antiplatelet drugs.
So is DES worth the trouble? Are these people living any longer than someone who does not have a DES stent?
I mean, as yet, we do not have any data to prove that.
So there's a lot of money going into DES stents without the evidence.
So far, you're right. We do not have evidence, but they've not been on the market that long either. They've been on the market only since 2003, I believe, in this country. And at the moment, there are only 3 of them on the market. There is the Cypher, the Taxus, and the Endeavor. So these 3 are on the market. And the first 2 are Cypher and Taxus are the first generation. They've been sold in Europe for a while, since I think 2002 or so. So they really have captured the market. And in the United States, we were using them in 80-90% of cases, which I don't think was required. And then, whether you should use them on-label, off-label, on-label being these are stable patients or acute coronary syndrome patients, but not acute myocardial infarction, not for left main, not in vein graft, not in bifurcation lesions. So there are indications for which they have not been approved.
There's a new stent out or coming out or in research by a company called X-Stent. Are you familiar with that?
I'm familiar with that, certainly.
So that is, I think, just longer stents, because I think one of the problems when you stent is, okay, you've solved that problem, but then they go on an infarct from another plaque downstream. So does the X-Stent stent solve that problem?
Now, one of the things that drug-eluting stents have had, this came out in 2006 in European Society of Cardiology, that there was a higher incidence of late stent thrombosis. But all trials that have been done, there is a slight increase in the rate of late stent thrombosis in stable patients. I think in stable patients beyond 1 or 2 years, I think these tend to heal. Those lesions tend to heal in stable patients. But I think when you start putting them everywhere where you don't know what type of lesion it is, you have an acute myocardial infarction. These drug-eluting stents are being used in patients with acute myocardial infarction. I don't think they should be used in those because our data would suggest they have a higher incidence of late stent thrombosis. So I think they should be used judiciously, not in every patient. I don't think there is need to use them in 80% of patients. I would say that 30, 40, 50% at most.
So we need to have a clone of you in every cath lab talking to the cardiologist before he stents somebody.
I don't think you can get a clone or you can get a person who will agree with me all the time. Most of them don't. But I think the data will suggest to you that they do cause problems.
Right. Well, you're challenging their belief systems.
Yes, but I think they're beginning to believe what I'm saying. We published data that we show that if we could identify cases where patients who have uncovered stent, means the stent strut doesn't have any neointium on top of it, there are no smooth muscle cells, no endothelium on top. The more the struts that are uncovered, that is, we showed that if they are 30% per section, you don't have uncovered struts, those are the ones that are going to thrombose.
If you've just tuned in, you're listening to the Clinicians Roundtable. I'm your host, Dr. Larry Kaskel. My guest today is the world-famous Dr. Renu Virmani, President and Medical Director of the CV Path Institute in Gaithersburg, Maryland, and we're talking about the real story on stents. Dr. Virmani, is there some sort of futuristic systemic approach like cryotherapy that would actually take care of the problem so we wouldn't need stents?
I'm not convinced cryotherapy is necessarily going to solve our problem. Maybe in the future there'll be, they've put paclitaxel on a balloon and they're saying that will solve the problem. We don't have to put stents. But I think these as yet have to be proven. The newer technologies have to be proven. I think overall, drug-eluting stents are a good idea. It's not a bad idea. That we can improve upon it. Part of it is, the polymers, you have to have better polymers. Part of it is we loaded too much of the drug on it, and we don't need that much drug for such a long time delivery. So there are things that we're beginning to learn that will improve the next generation of drug-eluting stents, like you suggested, X-stent. X-stent certainly has bioerodible polymer instead of a non-erodible polymer. It doesn't overlap. That's another thing which is very nice. One of the things we showed was when stents are overlapped, those are where we get into problem of stent thrombosis because there is much more drug there. You now concentrated the drug where you put one stent on top of another. So, there are things we can avoid, then the new generation of drug-eluting stents will be better. I think we'll master this. And we'll also learn which ones lesions need to be treated with a drug-eluting stent, which don't need to be treated. I think the future is bright. It's not to say that everybody should be getting drug-eluting stents. Absolutely not.
Can you tell me a little bit about what your experience has been with the newer bioabsorbable stents? And can you actually put a drug-eluting polymer in that stent? And do these struts allow them to stay open?
Yes, they have done this. Abbott has a stent called BVS. That stent is totally bioerodible. They have implanted these in about 40 patients in Australia and New Zealand, and they've published the data on that they showed in very pristine small lesions that these worked and that they didn't cause, there was only one incidence of thrombosis and there was no restenosis, and they have put drug on top of it. And they've now shown at 2 years out that the stent disappears. So it's a thought. It's a process, but I think it's a difficult process because the stent loses its integrity fairly quickly. And then if you had very calcified lesions, you couldn't apply them. So I think especially where they will be very useful are in young congenital heart disease, like if you have pulmonary stenosis, aortic stenosis, because as you know, if you put a metal stent, it doesn't grow with the patient. So that's where I think they have a great future.
I'd like to ask some more personal questions, if you don't mind. How did you become really the queen of coronary histology? Because it seems like your name is everywhere and everything flows through your labs.
Well, I wouldn't call myself the queen, but I would say that, yes, I do see a lot. And I trained at NHLBI, under one of the best cardiac pathologists at that time, I will say, William C. Roberts, who is very well known in the field of cardiovascular pathology and is still going strong. He has a journal called the American Journal of Cardiology. He's the editor of it. And I learned a lot from him, and then I branched off, went to the Armed Forces Institute of Pathology, where I had a laboratory of my own and continued to do research and publish. And I think everything is publishing and hard work. This is, I think, all what I did.
What do you do when a new company comes to you with a new stent and you do their research and their data's not so good? Do you have the power to essentially kill a stent?
I don't know that I have the power, but I certainly will tell them their stent is not very good. Don't put it in patients.
But then does that data just not get published?
Sometimes it gets published, sometimes it doesn't. I have to be honest. Some data will get published and some will die in the research field because it depends on the polymer. Supposing they put a polymer on a stent and the polymer is no good and we find huge inflammation, we do it in animals and we don't want to show that everything is bad because it could be that it had impurities and it was nothing to do with the polymer itself. So there are many factors which play a role in all this. But anything that comes on the market, I can guarantee you that we try and publish. That my first goal, I am a nonprofit organization, my first goal is to publish things.
So there's no product out there that you did the research on and advised them not to do it and it hit the market?
Well, yes, I would say one of the early stents, I was not in favor, but then the clinicians wanted to do it, and I said, no, I think this is a bad drug. You shouldn't be putting the stent in people. But they did it anyway because they listened to clinicians and not to me. But I really was the first one to tell them this will never work.
Dr. Virmani, what treatments or therapies that are emerging are you really excited about?
I think, there are newer ways of bioerodible is one way, but I think bioerodible on a metal stent is another way. I think just nitinol stents is another one that I like. Nitinol self-expanding stents, I believe, is the way. CardioMind has such a stent which is meant for small vessels. So there are new technologies, and also there are ways of treating heart valves, for example, percutaneously. That's very exciting.
You said you're a non-for-profit organization, so let's pretend for a moment that you were interested in money and you had $100,000 to invest in the hottest company that you believe is going to hit it big and have the stent that's going to take over the world. What would it be?
It hasn't come on the market as yet, but Terumo makes a very nice stent. It's a Japanese company, makes a very nice stent, and I think with the newer technology, bioerodible material on it, that is likely to come on the market will be very exciting.
Well, Dr. Renu Virmani, thank you so much for talking with me and coming on the show.
Thank you. Thank you for having me.
I'm Dr. Larry Kaskel, and you've been listening to the Clinicians Roundtable on ReachMD XM157. To comment or listen to our full library of on-demand podcasts, please visit our website at reachmd.com. And if you register with the promo code RADIO, we'll give you 6 months free of streaming ReachMD you can listen to day or night. You can also reach us by phone now with your comments and suggestions at 888-MD-XM157. That's 888-MD-XM157, and thank you for listening.